Welcome to the second part of dermatology. In this section, we'll be covering skin infections, drug reactions, staph scalded skin syndrome, and toxic shock syndrome, and finally, acne.
The skin infections are based on the depth of involvement. Impetigo simply refers to the most superficial of all the bacterial skin infections. It is from Staphylococcus and Streptococcus, but it's called impetigo because it involves only the epidermis. The names of the skin infections is not based on the organism. Impetigo, erysipelas, and cellulitis, furuncles, carbuncles, folliculitis, they're all Staphylococcus and Streptococcus. And not Staph epidermidis. Staph epidermidis lives there, but Staph aureus. But all the difference is, how extensive is the infection? If it's just superficial, it'll cause weeping, crusting, oozing, and draining, and be on top. Since it's on top, you could treat it with topicals, topical mupirocin, topical bacitracin, topical ritapamulin, which is easy to mispronounce because it's new, but it's a really cool drug. Now, severe disease needs oral agents, dicloxacillin, cephalexin. Cephalexin is an oral first-generation cephalosporin. Now, this is going to be difficult, but if they tell you that it is MRSA, this is only for minor MRSA infections like skin infections, doxycycline, clindamycin, or trimethoprim sulfamethoxazole. Erysipelas is deeper. It's into the dermis and the epidermis, dermis epidermis. It's more severe because it's deeper. It goes into that dermis. Now, it's still streptococci and staphylococci, but erysipelas is particularly more streptococcus. Now, the streptococcus on the skin is strep pyogenes, group A beta hemolytic strep. That's what causes erysipelas. It invades those dermal lymphatics, and it can cause bacteremia. It can cause a high white count or leukocytosis, a fever, and chills. It's a pretty severe thing. It's bad. And that's why it can be fatal if untreated. Can skin infections cause glomerulonephritis? Can skin infections cause glomerulonephritis? And the answer is yes. The skin infections can cause the glomerular disease, but not the rheumatic fever. Because erysipelas involves dermal lymphatics and it's swollen, it's very bright, red, hot, swollen, tender, warm. And a lesion is on the face. There's a leukocytosis, lesion on the face and a leukocytosis, and it's often systemic because it spreads. It looks like this: bright, red, hot, warm, swollen. Strep pyogenes, group A beta hemolytic strep, and it can cause kidney infections, but not rheumatic fever, but kidney, yes. Although erysipelas is more often from streptococci, you must treat for staphylococcus as well, unless you definitely have a diagnostic test like blood cultures that tells you for sure it's only strep. You got to treat for both. And the treatment of all skin infections is similar. Basically, it's the same answer for cellulitis, folliculitis, furuncles, carbuncles. The only one really that's different is impetigo can get topical antibiotics with the mupirocin, bacitracin, ritapamulin, and necrotizing fasciitis, which gets surgical debridement as well. Mild disease gets oral medications. Mild means no major leukocytosis, no fever, no hypotension, just skin infection only. And the oral antibiotics for skin, for staph and strep and strep and staph: oxacillin, cloxacillin, dicoxacillin, and ampicillin, dicoxacillin. Cephalexin, sometimes called Keflex, cefadroxil, which is another form of oral cephalosporin. Penicillin allergic patients can be treated with erythromycin, clarithromycin, and clindamycin. This is especially true for people with life-threatening penicillin allergies, like anaphylaxis. If you just have a rash to penicillin, can you use a cephalosporin? And the answer is, if it's just a rash, absolutely. Use that cephalosporin if it's just a rash. Use a cephalosporin if it's just a rash. Now, MRSA, and again, you'd have to be told in a question: doxycycline, clindamycin, trimethoprim sulfamethoxazole. But that's only for minor stuff in the skin. This would not be the answers for MRSA in the bloodstream. When disease is severe, you need intravenous medications like oxacillin, cloxacillin, dicloxacillin, and nafacillin, ox-clox, dicloxin, naf. Cefazolin is a first-generation cephalosporin. It's the intravenous equivalent of cephalexin. With a life-threatening penicillin allergy, remember, just a rash, use cephalosporins, but life-threatening penicillin allergy, clindamycin, vancomycin, MRSA, vancomycin, linezolid, daptomycin, tigacycline. That's the only drug in its class, tigacycline. It's called a glycylcycline. And ceftaroline, which is the only cephalosporin that covers MRSA. It's the only cephalosporin covering MRSA. The amount of cross-reaction between penicillins and cephalosporins is small. And if that allergic reaction is a rash, it's safe between penicillins and cephalosporins. You need that route of administration, oral or IV. This is a very good example of this. Cellulitis is a difficult word. What does it mean? Well, it means a soft tissue infection of the skin. It goes from the dermis down into the subcutaneous tissue. That skin is warm, red, swollen, tender. Rubor, dolor, calor, tumor. And here's a cool picture of that. The line on the right-hand side above the foot is a pen line. That's how you know when it's receding. Cellulitis. This is a picture of actually a patient from my own hospital, my own chief of infectious disease. And that is the bright red, hot, warm, swollen leg. You use a pen line to determine, is it receding? Cellulitis is more common in the legs than the arms, simply because legs have worse circulation. You're more likely to damage them. Cellulitis, by definition, means it's not a walled-off collection. You can't drain it. A walled-off collection is an abscess. This is not a walled-off collection. That's the whole point. That's why it's a soft tissue infection that's not walled off. Cellulitis isn't only at a hair follicle. If it's only at a hair follicle, it's folliculitis. If it's bigger, it's a furuncle. If it's bigger, it's a carbuncle. This is more diffuse. Skin infection is caused by Staph aureus, not Staph epidermidis. Staph epidermidis is normal commensal flora of the skin. Staph epidermidis lives on the skin as normal flora. The vast majority of people with cellulitis never get a diagnostic test. It's simply based on how does it look. How does it look? Looks like you get cellulitis, or it doesn't. The most accurate test, though, however, if you ask them a test question, is that you inject sterile saline in the skin and aspirate it and culture what you aspirate back. The problem is the yield is terrible at only 20%. And Staphylococcus is more common to grow than Streptococcus because Staphylococcus is often easier simply to grow. This treatment for cellulitis is the same as erysipelas. Topical antibiotics are just not going to get down there. They're too far. This infection is too far. This infection is too far under the skin for topicals to cover. Topicals will only cover impetigo. These are too far below the epidermal junction, and it won't reach. Well, the very name folliculitis means an infection originating around the follicle, the hair follicle. And these terms, well, they're old terms. They don't have a precise definition. There's no official exact cutoff. We can't say, oh, at 2 millimeters of folliculitis and at 5 millimeters of furuncle. It's a little too subjective for that. I'm sorry. So that also means you won't be asked. Now, the issue about severe disease is important because it means severe disease must be admitted to the hospital for intravenous antibiotics. And let's say for sure what severe means. Severe means fever, chills, and bacteremia. Folliculitis, because it's smaller, is the earliest and the most mild. It's an infection centering around the hair follicles. As it gets bigger, it walls off into a teeny tiny little abscess or collection of infected material. It's a furuncle. Carbuncle is a collection of furuncles, big ones. So that means that folliculitis is the smallest, furuncle is bigger, carbuncle is the biggest, and they all get treated with oxacillin, cloxacillin, dicloxacillin, and nafacillin, ox, clox, dicloxin, naf. Now, when we talk about methicillin sensitive and methicillin resistant, we really mean sensitive and resistant to oxclox, dichloxin, NAF. That's what we mean by methicillin. Methicillin's been off the market for 40 years. Methicillin causes allergic interstitial nephritis, makes you pee eosinophils. This is folliculitis because it's centering on the hair follicles. The answer for this would be a little oral dicloxacillin, nafcillin, cefazolin. This is much more severe. This is a furuncle, and more likely a carbuncle. It's like a skin abscess. In this case, it's burst open. Burst open. This furuncle is a small skin abscess. It's red, warm, hot, swollen, tender. It often needs to be drained to get that stuff out of there. Otherwise, oxclox, dichloxin, NAF, first-generation cephalosporins. If you have a life-threatening penicillin allergy, someone this severe should get vancomycin, linezolid, Remember, if the allergic reaction is just a rash, use cephalosporins. It's safe, it's just a rash. But if it's anaphylaxis, don't use a beta-lactam at all. Mild infections, macrolides, clendidoxycycline, or trimethoprim sulfa, there's zero cross-reaction between these drugs and penicillins. So if there's anaphylaxis, they are 100% safe. And a severe infection gets these medications, which also don't cross-react. Vancomycin, linezolid, daptomycin, tigacycline. Other medications that can also have anti-staphylococcal potential, but they're not MRSA medications. These drugs have an equal efficacy for staphylococcus as oxacillin, cloxacillin, dicloxacillin, nafcillin. In general, they are not first-line agents because the beta-lactam, beta-lactamase combinations are not necessary for most people. But if you don't have definite proof that you have a staphylococcus, and you might have gram-negatives or anaerobes, these drugs add gram-negative and anaerobe coverage. They're not first-line drugs, but they do also cover, including the carbapenems. Imipenem, meropenem, ertapenem, and doripenem also cover staphylococcus as well. Superficial fungal infections are also called dermatophytes or tinea. And tinea, and name the part of my body in Latin, corpus in the body, manum in the hand, pedis in the foot, crus in the groin, jock itch. Now they're all managed the same way, which is most of them are treated simply empirically. You give a topical antifungal. This is an example of the word ringworm, and here it's a great reason why it is called ringworm, because they're in a ring. Because also most of the organisms are in the heaped up leading edge, encircling it. No matter what the organism is, KOH, fungal culture, topical antifungals. Now by KOH we mean a potassium hydroxide. Potassium hydroxide on a scraping of skin dissolves the epidermal cells, and the epidermal cells are melted away but leave the fungi intact. That's because the walls of fungi have a tough substance called chitin, with the CH, chitin. It's the same as what's in a lobster shell or a crab, and it basically makes it impervious to melting away. And this is the basis of the diagnostic test. Potassium hydroxide will melt away the skin and leave the fungi intact. The most accurate test is a fungal culture. There's a big difference between what would you do and what is the most accurate. Most accurate is a fungal culture. What will I do? I'm not going to do a fungal culture unless the person's resistant, not getting better. The best initial therapy is a topical antifungal as long as there's no hair or nails involved. Topical antifungal agents just don't get through the nails. For hair and nails, like tinea capitis in the head or nails, tinea unguum, you have to use oral therapy. And those oral therapies are terbinafine, itraconazole, sometimes fluconazole, but these are the two best for hair and especially nail infections. Now the reason why these are much better than griseofulvin should never be the correct answer, is that griseofulvin simply has more duration of treatment. You have to give it for 6 to 9 to 12 months, much less efficacy. These medications are used for 6 weeks with 90% cure. That's pretty cool compared to griseofulvin. Topical antifungal agents are useful for all of the parts of the body that don't involve hair and nails. So let's go through those topical antifungals so you know what they are. And most all of these are available over the counter. Clotrimazole, you know it as Lotrimin. Ketoconazole, econazole, miconazole, turconazole, cyclopyrox. They're all available over the counter, and they all are about equally effective. Remember, though, oral ketoconazole inhibits the adrenals and inhibits male testicles. It is prominently causing gynecomastia because it's so anti-androgenic. As a matter of fact, oral ketoconazole has been used in the past to treat metastatic prostate cancer. It's so anti-androgenic it can be used in prostate cancer. Wow! The vagina and the mouth should be treated the same way. The same answers. Best initial test is a KOH, potassium hydroxide. The most accurate test is a fungal culture. The question that says, what do you do next, is neither of them. Straight to treatment with topical nystatin, topical clotrimazole, topical cyclopyrox, topical antifungal from the previous list. That's why when HIV came around in the 80s, we already knew what you could use for oral candidiasis because we simply took clotrimazole vaginal tablets and started putting them in the mouth for oral thrush and oral candidiasis because it's pretty much the same treatment. Drug reactions are hypersensitivity reactions to medications that vary in severity. Your major issue is to know the difference in severity between the different reactions. When the severity of reaction changes, the name of the reaction changes. When severity, that's what makes the name, is the severity of the reaction. They're all hypersensitivity reactions. Now, the drugs are also the same. The drugs that cause a morbilliform rash or Stevens-Johnson or toxic epidermal necrolysis or erythema multiforme, it's all the same drugs. Penicillins, 10% of the population is allergic to penicillin. 10% of the population is allergic to sulfa drugs. Now, here's where you have to go to medical school. Thiazides are a sulfa drug. Furosemide's a sulfa drug. Sulfonylureas are a sulfa drug. Propylthiouracil is a sulfa drug. Allopurinol is a sulfa drug. Phenytoin is a sulfa drug. Lamotrigine, there's very little cross-reaction with nonsteroidals, but they can. That's why they're allergenic. That's why every drug here can cause allergic interstitial nephritis and make you urinate eosinophils. The drugs that cause hypersensitivity reactions of the skin are the same as cause drug-induced hemolysis or interstitial nephritis. You don't have to learn them differently. Drug-induced autoimmune thrombocytopenia, you don't have to learn it twice. Invest your time now, and it's good for later on, too. A morbilliform rash is the mildest form of drug reaction. The skin stays intact. There's no mucous membrane involvement. That's how you tell it apart from the others. There's no specific therapy. Morbilliform just means it's in the form of measles. To the first antibiotic use in the 1930s, the guys didn't know what it was, and they developed the rash, and they said, gee, it looks like measles, because they saw measles every day. There was no antibiotics, but there was measles every day. That's all it means. Looks like measles. Wow, now if somebody has measles, most of you will never see measles. I see one case every 2 to 3 years. And that means if I saw a measles, I'd say, hey, it looks like a drug reaction. This is a morbilliform rash. Erythema multiforme literally means red skin in a lot of different shapes. It's a more severe, more widespread form of drug reaction. The lesions actually form into little targets. It's mostly on the trunk, and there is no mucous membrane involved. Mucous membranes are just not involved. It doesn't go into your lungs. Therefore, it generally doesn't kill you. Now, here's the extra one. In addition to all those drugs we mentioned, it also can happen from herpes and mycoplasma. And this thing about steroids and these drug reactions is extremely problematic. This one, steroids may benefit. And so the bottom line on all of these things is steroids doesn't clearly benefit any of them. Here's erythema multiforme, multiple small target-shaped lesions that can be confluent. That means into one big sheet. That is erythema multiforme. Again, no mucous membrane involvement. Stevens-Johnson syndrome is very severe. Stevens-Johnson means that you have 10 and 15, 20% of your skin involved. Wow, it's enormous. And it involves mucous membranes, and that's why it sloughs off that respiratory epithelium. And I have seen patients who got sulfa drugs and got phenytoin, and they ended up on a ventilator because they can't breathe. If it sloughs off the respiratory epithelium, you just can't breathe. And the big problem is that steroids just don't help. You so want them to help, they just don't. You're never going to figure out why intravenous immunoglobulins may work. We just don't know right now. But if it's very severe disease, that's what we're going to use. Toxic epidermal necrolysis is an even more severe form of the disease. It means that there's always mucous membranes involved. Nikolsky's kind, as the skin comes off in a sheet. Steroids definitely don't help, and you treat this with intravenous immunoglobulins as well. And the other thing is that it's a measure of it is simply the percentage of the body surface area involved. Stevens-Johnson is around 10, 20, 25, 30%. Toxic epidermal necrolysis is above 30%. In between 10 and 30% is unclear, but it's on a spectrum from Stevens-Johnson to toxic epidermal necrolysis. And here's a person that skin has come off in a sheet. Wow, look at that huge denuding of skin. Staph scalded skin syndrome and toxic shock syndrome are very similar to each other in the sense that they both cause major denuding of skin. They are both from Staphylococcus toxin. They both are throughout the entire body. They're different severities of the same event. You see, if that toxin from the surface of the staph results in skin involvement, with staph scalded skin looking similar to TN, including the Nikolsky sign, the toxic shock syndrome has skin involvement as well as life-threatening multi-organ involvement, low blood pressure, renal failure, liver dysfunction, CNS involvement, and confusion and delirium. That's why toxic shock is definitely something that will kill you right away. And both are treated with the anti-staphylococcal medications, oxacillin, cloxacillin, dicloxacillin, but particularly oxacillin and nafcillin, most effective. Cefazolin is essentially equal. Remember, it's okay if you have a penicillin rash, but remember, antibiotics are not going to reverse the disease. They are just to kill off the staph that produces the toxin to prevent progression. You think about it like this. If there's staph somewhere in sutures, nasal packing, it used to be tampons in the past, but nasal packing and sutures somewhere where the staph grows and you can't see it and it's hidden and it makes that toxin, you'll want to kill off the staph that's causing the toxin to be made. Mild acne is treated with topical antibacterials. Benzoyl peroxide, you can get over the counter. Now, if it doesn't get better, if it's ineffective, you add topical antibiotics, erythromycin, clindamycin, to control the disease. And a lot of people would control just with this. You don't automatically have to use vitamin A derivatives. The best initial therapy, topical antibacterials. Now, moderate acne needs the topical vitamin A derivatives. And the topical vitamin A derivatives like tretinoin, adapalene, tazarotene are added to the topical antibiotics. And if there's no response to the topical vitamin A derivatives, you can use oral antibiotics like minocycline and doxycycline. Finally, the most severe acne, and only the most severe, it's got to specifically say recurrent, progressive, benzoyl peroxide didn't work, topical antibiotics didn't work, topical vitamin A didn't work, oral antibiotics didn't work. It's stepwise. Then oral vitamin A. Then oral vitamin A. Only we go to isotretinoin because it causes hyperlipidemia, it causes teratogenicity. Can be very problematic. But you go in order. Benzoyl peroxide first, topical antibiotics, topical vitamin A, oral antibiotics, and finally oral vitamin A. Wow, ding! You just became a dermatologist for the first 5 visits.